Hi, my name is Jackie Beckerman, and I'm the Chief Patient Experience Officer at the University of Rochester Medical Center. It's an honor to be here today to speak at the National Prosperity Conference, but even more so to speak on this topic, which is so close to my heart, and I know close to my co-presenter, Carolyn's as well. Carolyn Nestro is a Senior Associate in the Department of Psychiatry and Director of Psychiatry's Office for Diversity, Inclusion, Culture, and Equity. So a few objectives of what we'd like to cover today. First, we want to have you learn how to create a successful patient-family advisory council, giving a voice to specific patient populations, because that is what it's all about. It's partnering with our patients and their families to implement needed change. To do that, we need to recognize and understand the difficulties and challenges of these often marginalized populations throughout our healthcare system. Hopefully, you'll see best ways to engage our PFACs. And I want you all to be able to walk away with some tools that can really help you to put these in place and ensure a positive experience for any identified population. So a little bit on who we are. University of Rochester Medical Center is a comprehensive healthcare delivery system in upstate New York. We're anchored by Strong Memorial Hospital, a large 850 and always growing bed tertiary care academic facility. We're busy. We have approximately 40,000 discharges annually, and our daily occupancy, this is important, runs 100 to 112, even 115% full each and every day. So that really means we're seeing caring for 2 to 3 inpatient units every day in the hallways, alcoves, ED boarding space, not ideal. And 115 ED visits and 2.5 million outpatient visits. Obviously, all these numbers are pre-COVID. I am pleased to say that we are back to approximately 100% full. And about 95% of our ED and outpatient visits, and obviously that's being complemented by telemedicine. So we have a long history of patient and family advisory councils. In fact, I think we started our first general council over 20 years ago. So we were really in the forefront of this movement. We're also proud that just recently, in the past year, we were one of 3 hospitals in New York selected for a site visit regarding our PFAC councils and some of the unusual councils that we'll hear about today. This was a program sponsored by Institute of Patient Family Centered Care and Haney's, the Healthcare Association of New York State. If you look at this, you'll see we have a pretty intricate network, okay? We currently actually have 7 patient family advisory councils. Obviously, the overall SMH, URMC, SMH, PFAC, which has representatives from all the rest. We have the Cancer Center, Children's Hospital, even the NICU, the more traditional, but then we also have behavioral health, staff, and our newest transgender and gender diverse PFAC that we just started a year ago. Which you'll hear about today. You can see that also we put these PFAC, we call them patient advisors, on many teams throughout the hospital. And even right before COVID, we were adding them to several direct patient care teams, and we hope to be continuing with that. We must have successful PFAC pieces. Caroline and I thought it would be helpful, since we've had such a long history on this, to just kind of go over some of the things that really are critical. Leadership, transparency, accountability, and influence is how we group them. You need the right person to lead this. You know, they're not always happy, and these aren't always easy conversations. You need to partner with the community. That is key, and engage your senior leadership. From the chart before, one thing, if you saw, our PFACs actually report up to our board, which I think just says how important they are within our organization. you need to share that data freely, okay? The good, the bad, and the ugly. I always have people who are very cautious, they don't want to share their dirty laundry. Well, guess what? These individuals know our dirty laundry, and we need to be open with them. We also have to discuss barriers to change. Sometimes, we are a big place. It doesn't happen quickly. They need to understand that. Can't stress enough follow through, okay? And providing that continuous feedback. One of the most frustrating things to a PFAC is to have given some great input and then never hear what happens. So you need to bring that back. And then publicly acknowledge and celebrate accomplishments. It's so critical, and there'll be lots of them. And, PFAC that works well will be holding you accountable. And then make sure they are empowered to impact change. Emphasize their essential role within the organization. It's our jobs to make their voices heard. We're a values-driven culture in our organization. Okay, we've been working on our eye care values for years, making sure they're not just words on a page. And one of the things I want to stress is how important it is to revisit those values routinely. And we do that. In fact, it was just a year and a half ago that our senior leadership, we all decided that, inclusion and diversity, it was present, it was under respect, but it wasn't there strongly enough. So just a year and a half ago, we added inclusion as a value, which I think very important message. And, we continue to update. And here's what we came up with. And this is with input from hundreds, staff, faculty, and even bringing patients into this. I will embrace diversity, be an ally for others, and acknowledge the value that everyone's story brings. And then you'll see getting to the behavioral level. We also tweaked respect slightly. I will be open and accepting of others' perspectives and treat each person with dignity and cultural sensitivity. So clearly things that are woven throughout our culture, and now we need to make sure they're in every part of our delivery. So why these groups? It is important to know your community. In Rochester, the deaf patient population is larger than any other place per capita in the country. Hard to get our hands around this exactly, but we estimate we serve at least 5,000 deaf patients. Behavioral health, studies that were done, 55% in the region reported personally dealing with mental or emotional health issues. We serve 36,000 patients annually and provide care for 300,000 outpatient visits a year. Transgender, we do have a large LGBTQ population. Hard to know exactly, but it's been estimated that about 60,000 transgender individuals live within our region. And I'm sad to say I have to point out poverty. Rochester has a poverty issue. We are the third poorest city in the US. Over 50% of our children live in severe poverty. And as we all know, that has great influence on disease, health expectancy, and obviously social, emotional, and physical health. So what are these populations telling us? What are these patients? These are all comments we've heard from either surveys that came in, if we do receive them, patient relation concerns, and just things that we've heard within the community. This is from a deaf patient. I was extremely ill, told I could not have the first available visit because there wasn't an interpreter available. I was forced to wait an additional 3 weeks. Or here was from another deaf patient. I was frightened after surgery and there was no interpreter present right then. I couldn't communicate with anyone at all. One of our transgender patients explained that in front of everyone, the nurse calling them in asked what people like me like to be called. That's how it was worded. And here's another transgender patient. Even though I corrected staff 3 or 4 times, they repeatedly used my dead name, jeering as they kept misgendering me. Their rudeness was so blatant, I felt dismissed and totally unsafe. I will never go back. And then behavioral health, we had someone voiced that they had waited for 3 days in the psych ED to get their child admitted. It was awful for them and for the staff. And here's one more. There was nowhere for families to go when we have to leave the unit for safety reasons if a person is out of control. They sent us out to wait by the elevators. It was so scary and exhausting. So as you can see, we clearly had work to do. And now we're going to talk about just what we've put in place to help with these changes. We're going to start with the deaf community and the deaf and hard of hearing PFAC. I think it's important that you hear the background. I need to say that personally, working with this community has been one of the real rewarding parts of my professional life, and I've just learned so much. This started, we knew there were some issues, but truthfully, we were not receiving that many concerns and complaints through patient relations. And we later learned that's just because often deaf people were not comfortable sharing their concerns. We were approached about 4 years ago from a local advocacy group, We the Deaf People, and they asked us if we would co-host a patient and family forum so that we could hear the issues that existed. Of course, we said yes, we were anxious. We had 125, it was incredible, 125 patients and families attend. And all of our senior leaders were present. We gave each person 3 minutes to share. And I have to tell you, what we heard really shocked us. We were letting these patients down in so many areas: access, experience, just all in all, we committed right then that we knew we had to improve. And we worked for about another year with We the Deaf People, and then realized we wanted to broaden and make sure that we had all voices from the deaf community represented. So we kicked off our group in February of 18. Recruitment, we went out to all deaf community groups and asked for representation. We had patients and families that had voiced their concerns in the past that we invited, and deaf and signing staff members as well. I have to tell you, it's facilitated by a deaf individual that partners with me, and that has been critical. Monthly meetings now on Zoom, you can imagine. This has taught us a lot with Zoom because we not only have the participants, we have 3 or 4 interpreters as well. And making sure everyone takes their turn so the interpreters can do their job. We further representation of the deaf on other committees, such as patient engagement, my chart operations, and we're striving to have a deaf member on all of our PFACs. I think it would be most meaningful for you to hear firsthand from some of our very special members of our committee. And I'm excited to have you here.
I got involved with the council because my oldest son was born with lissencephaly. And so he had a brain malformation that he was born with. And we were here at the hospital all the time. We were frequent flyers, so to speak, my wife and I. We've had great experiences here. We've had some difficult experiences here. And I've always wanted a way to share with somebody about how to make the deaf experience better here, but I never knew where to go with that feedback. It felt like wherever I took it, people didn't listen. And so I was just frustrated. And then my son passed away and we came to the hospital a lot less. And then I heard about the Deaf Patient Advisory Council. I learned about how much the community has to offer to the university and to the hospital. And I realized that this was exactly the thing I was looking for, and that this particular opportunity was exactly what I had been waiting for. I think here in the Rochester area, we have such a large deaf community, and we need that expertise, that lived experience represented somewhere in the medical system. I wanted to join the Deaf Patient and Family Advisory Council because I felt that it was incredibly important for the community to have access to healthcare that is truly accessible. And as a deaf person, my lived experience from my childhood up until now, there have been so many times, so many encounters within the healthcare system that could certainly have some improvement, not only as a physician, but also as a patient who has been in a number of hospitals. Thinking back to the beginning, I actually was not a member of the Deaf Patient Advisory Council when it was first created. I joined just a few years ago, and I have to say it has been incredibly impressive. And it's a true honor and thrill to be a part of it. I think it's been incredible. I've seen a lot of teamwork, and I've seen a lot of really positive changes come out of that advisory council. And in addition to that, the recognition of all the work from the deaf community members, myself included, all the things that we've done to inspire change, improvements for the deaf patients that come in for services here. The Deaf Patient and Family Advisory Council is comprised of people who are donating their time and efforts to this initiative. All of us have our own respective lives with family and work and other things, but all of us do recognize that the system could really improve. And because we know that there's now a mechanism for that to happen, it's really wonderful that people are able and willing and even excited to take the time out of their schedule to have these meetings. Often we have them at dinner time, which means that's time we're not spending with our families. But we are motivated and we are passionate. And so I encourage other hospital systems to create a space for deaf people and then listen to what they have to say. We certainly have a long way to go. We are nowhere near finished with improving the system, but we're not done. And there's a lot of team spirit, and I look forward to the changes to come.
So as you can understand, definitely an area we're excited to work in. We spent a lot of time, the group did, deciding where to focus. And it really came down to 3 areas: educational, operational, and personnel and staffing needs. All things that we really have kept working on, and I'll go into detail. We also had to address the data limitations. You know, this was not a group that really is completing that many of the Press-Ganey surveys. And, you know, something that we're working and need to work with Press-Ganey on. We did, though, go ahead and add questions about interpreters, because a lot of the issues surround interpreters, to each of the surveys, and then worked on getting more data from our own survey that comes through my chart if an interpreter is used. The deaf culture we've learned is really a storytelling culture, and much more of this information really is through qualitative data rather than quantitative data. In terms of some of the educational things that we've worked on, you know, just knowing the appropriate terminology. The term hearing impaired, something we use often in healthcare, it's actually extremely offensive. And, you know, I don't think people knew that. So we created screensavers. This is a way that's been very successful in our operation, just screensavers on all of the computers that are around all of the clinical areas. And this was a screensaver that the group put together. Don't use the term hearing impaired. It is offensive. The right term is deaf or hard of hearing or deaf-blind, if so. We also have patient panels. These members are very gracious, giving their time, participate, tell, share their stories to staff, nurses, at orientations, all different ways. And it's so much more of an impact for them to tell directly and talk directly to our staff rather than my just sharing their experiences. It's been extremely positive. In terms of operational enhancements, the group has been able to improve the timeliness of scheduling appointments. That concept of having to wait until an interpreter could be scheduled. We have a new program and it allows that, is definitely been improved. We also, as I said, created a process to obtain feedback on the individual interpreters, because we never had that kind of input. A deaf volunteer visitation program's been created and kicked off. As you can imagine, many of our deaf patients are among the loneliest because of the limitations with communication. The group helped create a communication toolkit for every unit and department, which I'll show you. A 24/7 text message line, they let us know was needed for urgent interpreter needs, which we put in place. And then we shared all this contact information on an important contact information card that we have out throughout the organization that's been extremely helpful. This is the toolkit I mentioned, with everything from signage to put on doors that let people know what language, if ASL is needed, interpreter, et cetera. It's been extremely helpful. And then for staffing needs, they told us they wanted a single patient relations contact, which we put in place. So that has been great. We have one person that has built trust within the community, and now people are often letting us know whenever an issue arises. They told us they needed a new deaf social worker, which we were able, our senior leaders came, heard from the group, and we were able to add. Interpreter services, we keep growing, we keep needing new interpreters. We've been able to hire some more thanks to the council's input. And they're actually incorporated into the interview process, okay, for some leadership positions, the social worker, et cetera. COVID's brought brand new challenges, as you can imagine. Masking is extremely difficult for the deaf. Just how we go through screening and disseminate all the information. The clear masks are helpful. It's hard to get them in stock. We're working on them, but we're also creating a new screensaver for staff to know if you have a deaf patient, ask for one of these masks. It helps greatly. Here's a symptom checker they built. This is laminated. Now it's at the doors. If someone is asking, how would they communicate with these masks and no interpreter, they can just hand them this sheet, very visual, and it's been extremely helpful. And then we started a video series. Our members have been gracious and are on video, sharing information through ASL. And we just started with just as simple as the visitation policy, and we'll be adding these and have them online in one location where all of them can be found. So what have I learned? A tremendous amount, even as simple as what's the right language. ASL, I've learned, is a language unto itself, and not every deaf patient speaks English or reads English. And that's been an important eye-opener. It's a language unto itself. The deaf interpreter, why people would want an actual deaf interpreter, which means we actually have two interpreters then in the room. And just understanding more about the deaf culture and how they communicate. And I think one of the strongest messages to all of us is just how privileged we are as hearing individuals. And we can't be making the decisions without input from the deaf. So what's next? We're hosting a forum, another patient forum, to share everything going on and hear more from the community. We were all ready to go before COVID, so we'll have to figure out how to do this virtually. That will be hosted by the PFAC. We talked about more surveying, continuation of staff, education, and expanding representation throughout for more diverse members. Clearly, we had two members members of people of color. One moved. We need to get more diverse membership, and that's really the #1 priority for the coming year. So at this point, I'm going to turn it over to Caroline, who's going to share all about our behavioral health PFAC.
Thanks so much, Jackie. So I'm Caroline Nestro, and I'm going to talk to you about our behavioral health PFAC, which is called the Department of Psychiatry Advisory Council of Consumers, better known and affectionately known as DPACC. So what DPACC has really helped us with is to value listening to and learning from those we serve, as Jackie has been talking about. And this is one picture of one of our DPACC members, teaching our new nursing staff orientation class, which I'll mention in a few minutes. So a little background on DPACC. In 2006, I was running a bunch of adult ambulatory services and really felt it would be important to have patient family input because I knew we could do better and I wanted to make changes. So our very first meeting, the members of the group let us know that our focus was not their focus. So we changed our focus from that very first meeting, and they were right. They wanted to talk about everything other than adult ambulatory services. They wanted to talk about our psych emergency room services, our inpatient services. So we broadened our scope from a narrow program perspective to our full continuum of care. And ever since, their areas of focus have truly guided our patient family-centered care initiatives. They helped us understand the importance of including their voice for guidance in all that we do. And a quick example of that, I sit on our Quality Council Committee, and many years ago at one of the Quality Council meetings, the physician leading the meeting, they were talking about our partial hospitalization program and some clinical concern they had. The physician leaned over and said, Caroline, what would DPACC say about this? And I said, well, I could guess what they would say. I said, but if you really want to know what DPACC would say, get on the agenda for a meeting and you can find out. And that gave us the idea to create these buttons that you see in the corner there. I actually have one here as well. What would DPACC say? And we handed these buttons out to all of our leaders so that if they were considering making some kind of a change in the clinical area, they would think, what would DPACC say? And if they didn't have any idea what our patients and families would say, they would get on the agenda for one of our meetings. Currently, we have our general DPACC, and we actually do have two sub-councils to our DPACC now. We have a family advisory board for our child and adolescent psych services, and we have a strong recovery addiction PAC for our addiction services, because they really wanted to focus much more than they could in monthly meetings in the general council on issues that were more pertinent to their programs. Today, our DPACC members sit on our incident review committee in the Department of Psychiatry. They take part in interviewing candidates for top leadership positions, and they're very active with us, and we really count on them. I wanted to share this slide just because I wanted to sort of take the mystery out of how to start one of these patient family advisory councils. For me, back in 2006, it was as simple as sending an email to all of my coworkers saying that we needed to start one of these and did they have any patients or family members who might be interested in helping us to improve our practices. So not rocket science, pretty easy to do. And we just tested the waters that way. And if you want, you can call it a pilot so that you don't have to feel so committed, but just get going if you don't have one started already. Our current DPACC membership and member criteria, presently we have 10 consumers, 7 family members, and 3 staff members on our DPACC. They need to be adults 18 and over, although we do have a mother-son pair on our DPACC right now, and I believe our son is 16 at this point. They have to have present or past recipient of our services. We accept anyone with a variety of mental health concerns. Right now, they're recommended for the council by a treatment team member or by a DPACC member who knows another person who might be good on DPACC. For a family member, they have or had a family member or significant other utilize our services, and they generally need to have some interest in advocacy or are concerned about the quality of care. And for transparency, most of our DPACC members have become members because they had some pretty difficult situation with us in their care. And those members have become incredibly helpful DPACC members to us. The criteria that members need to meet to be on a DPACC is the ability to share personal experiences in ways that others can learn from them, the ability to see the bigger picture, an interest in more than one issue, the ability to speak candidly in a group, the ability to listen and hear other points of view, and the ability to connect with people. And generally, people may start off a little quiet in their first few meetings, but it's been wonderful to watch them kind of bloom, especially our patient members, over the years and really become advocates. So benefits of partnering with patients and families. They really have helped us in four general ways at the individual experience level. So when they share their experiences, it's sharing their experiences of the care we provide, very different than sharing their experience of living with a mental illness or having a family member with a mental illness. Here, they're talking about how it is to be cared for by us, which is very powerful. They've helped us at the practice and policy level, at the community partnership level. Many of our DPACC members are very active in other organizations in the community and mental health related organizations. So they've really helped us to partner with those organizations as a department. And they help us at the research level. Our researchers, especially when they're doing clinical research, they know they can come to DPACC and get the patient family perspective on a consent, on whether or not this is a good research idea. And we actually have some DPACC members who now partner with our researchers and are part and parcel of research studies. So having a DPACC there has really expedited many things for our department. And for us, it really it follows our department mission, four missions, which is clinical care, education, research, and community. The accomplishments that DPACC has helped us with are many, and I'm not going to go through a lot of them. I'll just give a few simple examples, as Jackie did in the previous, talking about the DPACC. For instance, informing patients and families about comfort items in our psychiatric emergency department. They never even had a sign up. And one of our patients, in her story, when she was in our psych emergency department after many weeks not sleeping with a terrible migraine, she went up to leave and got restrained. Had she known, she said, that they had earplugs, she would have asked for earplugs if that sign was there, and it could have really saved her from that very traumatic experience of being restrained in the psych emergency department. Another one fairly recently is they helped us soften the look of these barrier-resistant doors that we have on our inpatient units. When these doors were installed, everybody was really, really concerned. They looked very prison-like. And DPACC was really concerned about them and did some exploring and problem solving and ended up with putting these decals on the doors, which have really softened them. A very big initiative that DPACC has helped us with is they put on the radar for us, because it was not on our radar, that we needed a family lounge for our families of inpatients in psychiatry. The medical center has a family lounge, but it's very, very far away from our inpatient units. And the one on the medical side is supported by the Ronald McDonald House.
I got a washer and
So
dryer.
DPACC members really campaigned and advocated for us to have one on our side of the hospital. And Ronald McDonald House heard about that, reached out to us, and created this family lounge for our families who have inpatients on the inpatient units. And in our department of psychiatry, space is really a premium. So for the fact that we got this very lovely room and they let us expand the room was all because of DPACC's advocacy. Ronald McDonald's House also surveys people who uses this room, and 97% of families said it helped them to feel more relaxed and rested when they use the lounge. And about 94% said that it really enabled them to better provide support for their child. Another really big campaign that DPACC went on was they really wanted to help our psychiatric emergency department have better efficiency, less wait times, and improve the quality of service there. And DPACC has really partnered with our psych emergency room leadership. That leadership comes twice a year to a DPACC meeting. And one of the things that DPACC did was they decided to write a letter to hospital and department leadership asking for a pretty large increase in staffing. They finished the letter, many of them signed it, and then it was up to me to send the letter to our hospital and department leadership. Eleanor Roosevelt said, do one thing every day that scares you. When I pressed send on this email to those leaders, I must say I was pretty scared. I had never done anything like this with DPACC before, but literally within 10 minutes, I got responses from that leadership. And not only in a little bit of time did our psych emergency department get this amount of staffing, but they got more than what DPACC was even asking for. I wanted to just say a little bit about the education highlights. Our DPACC members really do a lot of educating. where they talk about their perspective of getting care from us. Now they talk to every new psychiatric nursing orientation group. They speak annually at our postdoctoral psychology fellows academic development seminar. They speak at other area colleges now, like Nazareth College of Social Work. They work with our medical students to teach them how to do psychiatric interviews, and they've also presented departmental grand rounds. So I've said enough, and I'd like you to hear from some of our DPACC members, including from my co-facilitator of DPACC, Patrick Setch.
I have to say that, DPACC has been definitely one of the cornerstones of my recovery. It's been very cathartic for me to feel like a part of something and feel like a part of change and be a help, and also to meet other people that are on that recovery journey and to meet other family members that are supporting their loved ones. Like a lot of people, I had mixed experiences here when I was a patient. I was a patient here for a month in 2014 after my second suicide attempt. I'd had some mixed experiences in the comprehensive psychiatric emergency program. And as an inpatient, I also had some mixed experiences. Ultimately, fantastic care that set me on the road to my recovery. But I'm a big believer that you can't change the past. You can't do shoulda, coulda, wouldas. You can't, harbor resentment if you want to move forward. And so I wanted to join DPACC to help things move forward for other patients that come after me.
I wanted to join DPACC because I wanted to make a difference. I wanted to help with change. I really wanted my son, Timmy, who is the reason that I'm here, to know that just because he has an illness, it doesn't mean there's things he can't do. And so I wanted him to know that there is a positive in everything, and this is my way of helping to make something positive out of an illness that can at times be very hard for both of us.
So DPACC is extremely important to me. I was a part of starting it and continue to remain active in it is because I don't think we can fabricate the consumer's voice. That the only way for us to get the input that is necessary to ensure that we are serving our population the best possible way is to have their voice. And DPACC is that voice for us.
I think DPACC has a very strong place in the hospital because it gives people voices, the voice to express things that have gone good, things that have gone bad, maybe policies that need to be looked at and re-examined. There's been a lot of work with different types of paperwork, various things that have been brought to our table, so to speak. And being a consumer, I think it's really important that we have a voice to make those changes.
It's just a platform for a lot of different people to get their voices heard. And we really are heard. Our voices really do make a difference.
Thank you, Caroline. It is wonderful to hear just how embedded into the department your DPACC is. And I can say, having been to several of their meetings, they're a wonderfully engaged group. Okay, so I'm now going to transition to the transgender community. So being in charge of oversight of all the concerns and complaints that come into the medical center, you can imagine I've heard lots of stories. But I do have to say, definitely some of the most heartbreaking stories I have heard have been those of the transgender patients. Our background as to why we actually went and started this, well, we had a few very significant complaints, really horrific on many levels. And one of them actually made it to a local magazine, The Empty Closet. And reading it, we realized that we really wanted to put a response in and an apology. And so we reached out to the editor, and we literally had a whole page of our writing, not just an apology for letting the individual down, but a public commitment to do better for this population and the transgender and gender diverse. And, we realize it takes time because, there's a lot of trust has been lost. We started then with an internal group we created, Thrive. This was a group made up of providers that care for transgender patients, as well as a few employees that are transgender and work with that population as well. And they really kind of decided what needs to be done, and education across the board. Okay, people just, don't understand things. It just makes it so much worse. And we realized just how important education was. Also, just some operations, e-record changes, new policies needed to be created. We hope, we have not done this yet, but the creation of a transgender clinic, okay, is on the horizon, I'm pleased to say. And one of the things absolutely they felt was the implementation of a patient and family advisory councils, particularly with our history. It just made sense. One of the things I'll just point out that the group created, and I'm pleased to say out of my office, we have pronoun badges now. These actually hang below our IDs. Anyone can wear them that want them. I know lots of places have buttons. What I like about this is they're very official. They're part of our ID. And so that again helps. And with the blessing of Thrive, we did kick off into literally a year ago, our PFAC. I mentioned trust, and I have to say it's true for all of the different groups we work with, but particularly, as I said, with the transgender community, trust is earned when actions meet words. And we realize it is going to take time. So it hasn't been, it's been a bit challenging to get transgender patients to join. One of the things I've done is partner with a transgender employee who is facilitating the committee with me. And he went to all these community organizations. It would make no sense for myself to do that. We had a flyer, talked about what we wanted to do. And I'm pleased to say currently, including the facilitator, we have 6 transgender individuals. We also invited families with quite a few parents, 6 parents of trans teens, and 1 gender diverse individual. We just heard there's a couple that wants to join us, a husband and wife that we're excited to have join as well. So again, recruitment, it's just ongoing, and we are hopeful that as news travels, that changes are underway and that we really are serious about improving things, that will have more membership as well. I'm going to have you now hear directly from some of those key people that have helped us kick this off. So important to hear from their voices.
So about 2016, my son was, I dropped him off at school, and he passed me a note saying that, Mom, I don't think that I like being in my body. I think I'm transgender. I don't want to live as a female. I want to be a male. It was kind of a shocking revelation to me, unexpected completely. He ran off into school and didn't give me any time to respond at that point. I went to work not knowing what to do.
Some people think just because I get out of my bed like they do, that our walk is the same to get to work at 8 o'clock in the morning the same time, but it's not. My barriers are much different. I deal with a lot of change, social change, things that are not changing socially in our community, especially now with Black Lives Matter. And it's tough. And on top of that, I have to deal with the fact that I am a trans person, and that I have to always walk a different walk, even when it's time when I go into the lobby, and worry if somebody's going to say something nasty, and then and you know, all those nasty comments, that those things weigh on you daily, and that's what I go through every day.
The Transgender and Gender Diverse Patient and Family Council is absolutely crucial in our hospital system. A lot of times we don't even realize the unique needs that individuals have and the barriers that impact individuals obtaining health care. We're looking at individuals that often don't go to their basic primary care providers because they've got doctors that are discriminating against them, not using their name and pronouns, that aren't knowledgeable about trans and gender diverse individuals, let alone their unique healthcare needs. We've got individuals that may have been afraid to come to the hospital system, but if they feel like there's this sense of respect that their voice is being heard and we're listening to them, from everything from what does it feel like to pick out eyeglasses when that's gendered and male and female sections, to what is it like going for a mammogram and everything is flowery and pink and that doesn't represent me. And so there's so many things that we forget to think about on how does this impact somebody.
I think the Patient and Family Advisory Council is essential to give patients a voice, to be able to express their opinions and give input on policies and procedures that affect them directly.
I feel that it's important that we have a transgender diversity council, because when I heard about it, being transgender of color, most likely, we don't get a chance to have a voice. And when I found that I could actually have a voice that involved making change for others in my community and for people who are like me, it was an opportunity I couldn't miss.
So as you can see, very, very committed individuals. We have been able to work on some projects, even in the last year, a lot to make e-record changes that are transgender friendly. We also remove gender markers. As you can imagine, one of the most painful things we do here are individuals who spend their life being the people they are meant to be. And the first thing we do when they come in is put a wristband on with their sex at birth. Extremely, talk about unnecessary suffering we put people through. We removed them. Actually, we didn't really ask a lot of people, we just had them removed. No one came back and said they were needed. We took them off forms that were patient facing. Preferred name. First of all, I have to say, we've learned, rightfully so, that this is not a term that the transgender community likes, because it's not their preferred name, it is their name. Unfortunately, preferred name is a term that's used in e-record, so we have had to stay with it because that's what staff know, but we have been able to make that name front and center. That's the name that's now enlarged, not necessarily the birth name, but that preferred name on any place where their name is found. We've been able to override default pronouns and make those name changes. Not only, obviously, if people legally change their name, we change it instantly in the medical record when it's brought to us. But even if they haven't gone through that process, we put that their name, preferred name, I keep using because that is what it's called in our system, out there as much as possible. They've provided input into our training. We realized everyone needed an online training module that was created. They gave us great input. Just recently, our last meeting, they helped us figure out what is a new name for the Women's Health Clinic. As you can imagine, that is not an inclusive name. And for transgender men who need to have maybe meet with a gynecologist, you can imagine how uncomfortable it is to sit in that waiting room in the Women's Health Clinic. So they gave us great input. A new rooming policy was created. You know, often what was happening was people were just, because they thought this was the best for everyone, we were putting transgender individuals into private rooms, which often meant they were sitting in the ED for longer, waiting for the room. No, we have a new rooming policy now that is much more appropriate. They helped us write the scenarios to accompany that rooming policy. Okay, it was not the scenarios we brought to them initially where we ended up. Great input we received. And again, these screensavers that are so well utilized in our organization, they worked extremely hard to develop this really very simple 5 tips. Use preferred first name. Use my pronouns. If you're not sure how to address me, please ask me, okay? And you can see in the bubble, I want to be respectful. How would you like to be addressed? If you make a mistake, apologize, but then move forward, okay? That was something we heard from all of our members that they wanted to have shared with staff. And then where to get more information. So again, these are up all of our clinical sites. So where do we go from here? I think this kind of summarizes. This is a note that was just sent last week from my co-facilitator to the group. And I think he just said this so perfectly. We want to understand from you what you need from this group to feel supported and heard, what agenda items may be of value to you moving forward, and where we've dropped the ball and could have done better. Ultimately, we want to check in and learn from you what matters most, because you are what matters most. And I think that says it all. Great news is we got a lot of response, and we're checking in with people as we continue to move forward. But we are confident now that at least we have the mechanism to really start creating the changes that's needed. So I've always loved this quote: coming together is a beginning, keeping together is progress, working together is success. And that's where we are now. We are really partnering with these communities. So I'm going to hand it back to Caroline to really talk about the tips that we've learned for success and sustainability.
Thanks so much, Jackie. So we have learned a lot over the years, and we continue to learn. Some of the tips were co-facilitation is really important when you're running a PFAC. Experience that I had early on was that I was the major facilitator who was needing to do all of the follow-up after the meetings, and running the DPACC is not the only part of my job. I have quite a lot more that I do. So for me, making sure that I have co-facilitators who can help with follow-up was really key for us to be able to be accountable to our DPACC members. And Jackie, did you want to add to that?
Just as I said, we could not do this without the community. So having facilitators, particularly in the deaf and transgender, that are members of that population was just so helpful and really made the difference.
Next was really making sure that you are engaging your leadership, reminding leadership that these PACs are incredibly helpful. So one of the ways that we do that, every year in DPACC, we have an anniversary meeting, which actually is this month, where we invite department leaders, we invite leaders from the medical center to come and hear. What we do is we review everything that DPACC has helped us with in the previous year, and we talk about priorities for the next year. So that's one way that we make sure we continue to engage leadership with our DPACC so that they remember that they're there for their use as well. Jackie?
Yeah, I also want to mention, so we have also done something on an annual basis. We bring together all of our PFAC members together and bring senior leadership there, as well as to the separate meetings throughout the year. But it's a really nice session. Our leadership tell them what's going on, so they are in the know, and then hear directly from the group. I'll never forget having our COO hear for the first time from one of our deaf members what it is like to be at the doctor and tell your symptoms, which is really how you get diagnosed, all through a third party. And so how important those interpreters are. So hearing this firsthand is key. I'm going to pass it back to you, Carolyn, for the next.
Assuring opinions are valued and acted upon. I mean, DPAC members are there volunteering their time to really help us improve what we do. And as one of our members always said, she would not be on DPAC as long as she's been if we were only window dressing, she said. And she knows that they're not only window dressing because she, over the years, has really seen that what they have said has really made an impact. So in addition to our anniversary celebration each year, and we usually have it over a very nice dinner, we're going to have to do it differently this year for COVID. Anytime there are any perks, because these people are not getting paid to help us, we try to have perks go their way. If there's a local conference, maybe we'll purchase a table so that DPAC members could come to that conference if it's a mental health conference. For our 10th anniversary, for instance, we made mugs, DPAC mugs, and filled them with mental health promotion items for our DPAC members. So we really try to let them know that we value their opinion and that we really need them. And anytime we can, we throw a perk their way if we can. Anything to add to that one, Jackie?
Well, really, celebrate, celebrate, celebrate. And I'm going to be proud here to announce that tomorrow night, we are actually, the Deaf Patient Family Advisory Council is receiving an award from the Greater Rochester Quality Council for the work that has been done for quality improvement. So we're excited.
As Jackie's mentioned, ongoing recruitment is always something that we need to be doing. We do have many members that really stay with us because they really find it, they feel needed there. They know that they're being helpful there. But typically I will do recruitment around this time of year. So anybody who might be interested can come to our anniversary meeting and hear about all the accomplishments from the previous year and also hear the kinds of priorities that we're going to focus on for the next year. But as Jackie also mentioned, we really are trying to increase the diversity of our membership. We've had very diverse members over the years, but people do move on. So recruitment is very important.
I just wanted to add that when we do recruit people, and I know Caroline does this too, we typically meet, the co-facilitator and myself meet with the individual, just to let them really understand what the council is all about, but also because you want to make sure that the individual does not have such a personal agenda that maybe it wouldn't be a great addition to the group. It doesn't happen very often, but we do think it's an important process to go through.
For DPAC, we actually have a short application as well that people need to complete. And that is the cue for me to either talk with them by phone or meet with them, as Jackie said, just to make sure expectations align. So that's a positive experience for them and for the council. Again, it's not enough to invite people to the table. You really need to engage their participation. And as I think I mentioned earlier, sometimes members are very quiet initially, and there are other members who are not quiet at all. So you really need to make sure that you are inviting some of the more quiet members into the conversation because they're there for a reason and they often have ideas. So you want to make sure that you are including them at the meetings. Jackie?
Yeah, I'm just laughing because this is something I learned from the Deaf Council. For people like myself and others who may be talkers, you know what? When there's an interpreter involved, you need to raise your hand and wait, and they will call on you. So the great thing is we call on everyone and make sure that everyone there each time has the opportunity to say something. And you know what? It really does help. So, you know what? I think we really want to say, think out of the box, okay? If you're having trouble getting people to meetings, if they're in person, because of babysitting, then get a babysitter to be present. If being at the medical center isn't a safe place, then why do you have to have the meetings there? Is there somewhere else in the community? These are the questions we keep asking ourselves so that we can be more successful. And Carolyn, you can go.
I would agree. And actually, DPAC has really helped us to think outside the box. They'll bring something up that truly we weren't thinking about. And our immediate gut reaction is, oh, that'll never happen. But then they help us to make it happen. So they help us think out of the box when we're not doing so. And I think overall, they really have helped us in ways, more ways than we ever imagined. And I think it would be the same for all of you too. If you don't have any patient family advisory councils now, or if they're working at a low level, please think about everything that we've been telling you. And you're invited to reach out to either of us if you have further questions about this. We're very happy to help people to get these started because they will help you in more ways than you could ever imagine as well. Jackie?
Absolutely. So as an organization, we're next. As we said, number one priority for all of our PFACs, expanding diversity. Your PFACs need to represent all of the patients you serve. We're actually exploring the creation of a diversity, equity, and inclusion PFAC, okay? What could that look like? Would it be a subcommittee of our general group? I mean, all these questions. But we're definitely talking about that, and it may very well be a direction we could turn. Again, getting the right metrics so that we can measure success, because you know what, sometimes the traditional surveying does not always work for these populations. And I guess we, both Caroline and I want to say, you know what, we're not standing here or in front of you giving this presentation because we have it all figured out, because we don't. And they let us know that. But we do feel very confident that this is a great way to truly create the change needed. We could never do this without the voices of our patients and families. And on that, I thank you. Caroline thanks you, and we're happy to answer questions when we have the opportunity to do that.